Hi, my name is Hanaa Rajabally and I'm one of the Rheumatology registrars, and I'll be talking to you today about giant cell arteritis, which is one of the emergencies in rheumatology. So this presentation is for Foundation Year 1 doctors, and my presentation will cover the following curriculum outcomes. So I'll be going over how to take a history for a patient with suspected GCA, how to examine them and have a management plan, and also how to prescribe steroids safely after counseling the patient and going over the side effects of steroids, and also safety netting regarding visual symptoms. So I'll be first starting by presenting a couple of cases of patients that I've seen in clinic, and it's really to put things into context. So the first patient is a 65-year-old man who was referred to rheumatology with a 2 weeks history of headache, sharp pain in the right eye, excessive lacrimation in the right eye. He did not have any jaw claudication or any polymyalgia symptoms, and there was no visual symptoms either. His inflammatory markers were normal. So any diagnosis at this point, what should we be thinking about in this patient? So I think it's reassuring that the inflammatory markers are normal and we're not really thinking about inflammation. So the diagnosis in this case is cluster headache, and typically it can be associated with nasal congestion, and the attacks occur in clusters. I think if I mentioned the word clusters, you would have probably got the diagnosis straight away. And the treatment in an acute attack is verapamil, oxygen, and you could also use triptans.
That was very sneaky. I was expecting you to go a different route there.
So the next case, I want you to contrast this case. So this is a 55-year-old lady who presented with a severe headache. About 6 months ago, she presented to her GP with a severe headache, neck pain, tender scalp and jaw claudication. So this poor lady had very severe symptoms, and she had seen her GP who referred her, to the vascular team, and then she subsequently saw the stroke team and ended up under rheumatology because nobody really quite knew what was going on. So after developing the headache, she developed tingling about 2 weeks later and weakness in the right arm. So an MRI of her brain was arranged, and this showed stenosis in the left internal carotid artery. And an ESR at that time came back raised at 84, and already I think the GP was thinking this is probably a GCA. So the GP started prednisolone, but at a subtherapeutic dose of 15 milligrams, and her symptoms resolved to start with, but she continued to develop further symptoms like leg claudication, and she was referred to the vascular team, who did a CT angiogram, and she was found to have occlusion of both superficial femoral arteries. She went on to have a temporal artery biopsy that did not confirm any giant cell arteritis. And when I saw her in clinic, on the clinical exam, she had mild carotid bruit on the left carotid artery, and she also had a reduced volume of the radial and dorsalis pedis pulse on the left. And there was a discrepancy in her blood pressure between the left and the right arm, the blood pressure being lower on the left. And these are all signs of reduced circulation on the left due to her stenosis. So at that point in clinic, the rheumatology consultant advised increasing her steroid to 60 milligrams daily. And unfortunately, she went on over the next couple of days to develop further neurological symptoms, including slurring of her speech, left-sided facial weakness, and understandably, the patient was terrified of a large catastrophic stroke, which luckily didn't happen. But I think we were worried enough to start her on methotrexate as steroid-sparing agent, and a few weeks later, we started her on tocilizumab for further immunosuppression. She's currently doing well. She's not had any further episodes of vascular symptoms or neurological symptoms. So in this case, this lady had a good outcome. So giant cell arteritis is the commonest of all the vasculitides, and the worry with GCA is that it can cause visual loss in about 20% of cases, and this rate is high and it's bad if a patient has visual loss. And it's because most cases of visual loss is irreversible. So once it's happened, there is really not much you can do, and it's devastating for the patient, both in terms of their function and their quality of life. So really, we want to pick up symptoms of GCA early and give the patient the right treatment to avoid these adverse outcomes. So the typical clinical feature is that GCA present usually in patients of more than 50 years of age, and they tend to develop an abrupt onset headache, usually unilateral in the temporal area with scalp tenderness, and they can also have jaw and tongue claudication. Now, it's very important to know how to elicit jaw claudication in the history. I find it useful to ask open questions, so things like, tell me about how you feel when you chew your food. Tell me about how you feel if you eat a piece of bread or a bit of meat. And then let them tell you, if they have true claudication, it will come out in the history by the patient themselves. And try to avoid closed questions like, do you have any pain in your jaw when you're chewing? Because what happens in these cases, most often the patient will say, yes, I do. And then it's difficult to find out, is it from osteoarthritis in the temporomandibular joint, which is quite common, or is it from temporomandibular joint dysfunction, where a patient can get a click in their jaw? So it's important to know how to elicit this in the history.
I think people are trying to be helpful as well, because they say yes just to feel helpful.
Yes, and you're misleading them. Try not to ask leading questions and keep it quite open. Because jaw claudication is a very strong positive predictor of giant cell arteritis, and it's crucial to get this right when you're taking the history. The other symptoms associated with GCA is visual symptoms, diplopia, blurring of the vision, and we will get to that later in the examination section. Patients can have constitutional symptoms like a fever, weight loss, malaise. They can develop polymyalgia rheumatica, which is stiffness and pain in the shoulder or hip girdle, and this is associated with GCA. And they may have limb claudication if they have stenosis in their large vessels.
One thing I was going to ask is I was always taught that you don't see many nevers in medicine, but you never see GCA temporal arteritis in people younger than 50.
Yes.
Do you ever see people younger than 50?
No.
So that's always like the age cut-off, right?
Yes.
Fair enough.
So a lot of time we have GP referrals, or GP calls for advice about a patient who's in their practice at the moment with they're maybe 40, 45, and they've got this sudden onset headache. Is it GCA? Is it worth doing an ESR? And the advice is no, we wouldn't really even think about GCA in that patient group.
So is that crystal clear?
Yes.
Right, that's very unusual in medicine. You never get that clear.
Yeah.
That's good.
But I think it's worth remembering, although you need to have GCA on your list of diagnoses, a headache with raised inflammatory markers is not automatically equal to a GCA, because there's more common things. So think about infection. Is it meningitis, encephalitis? Think about malignancy as well. So on clinical examination, you would expect to find a tender, thickened temporal artery with a reduced or absent pulsation. So take your time and have a good feel over the temporal artery, as much as is comfortable for the patient, because they're already tender. There may also be scalp tenderness, and as I mentioned before, the visual symptoms include visual field defect, a relative afferent pupillary defect, anterior ischemic optic neuritis, and upper cranial nerve palsies affecting the optic nerve or the oculomotor and trochlear nerve, which are responsible for eye movements. So it's worth checking eye movement as well when you're examining them. And other features to look out for is a vascular bruit. So I tend to listen over the carotid artery, and asymmetry in the pulses. So have a feel of both pulse, radial pulse or dorsalis pedis pulses. Make sure they're synchronous. Make sure the volume is symmetrical on both sides, and then check the blood pressure in both arms. To make sure there's no stenosis in the subclavian artery or the carotid artery. So at this point, if anybody has any questions, I'm happy to clarify anything.
Yeah, you can leave comments in the box below.
Yeah, you can leave comments, yeah.
I'll try and forward them to Dr. Rajabally if you have any particular ones.
So moving on to the investigations, I'm sure you're all aware that the most common thing to look out for in GCA is a raised ESR or a CRP, and that would confirm, that there's some inflammation going on. Sometimes patients can have anemia or raised platelets as an inflammatory reaction. We would also do a chest X-ray to look for mediastinal widening, and that's because it's important to think about aortitis, as GCA can affect, the aorta. A urinalysis is important to check for protein and blood in the urine. And then a temporal artery ultrasound is widely used to look for signs of inflammation in the temporal arteries. In Sunderland, we request it via radiology, but in rheumatology specialist centres like the Freeman Hospital, the rheumatology consultants are trained to do the temporal artery ultrasound within the department. So if the ultrasound is equivocal or normal and the clinical suspicion is high, then we can arrange a temporal artery biopsy by liaising with the vascular team here, or in Newcastle it's the ophthalmology team who carries out the biopsies. And if the biopsy is negative and we really are suspicious of vasculitis, we can go on to request a PET scan just to look for any signs of large vessel vasculitis. So the next slide shows images of the temporal artery on ultrasound. So on the ultrasound image A, you can see there's a nice uniform temporal artery, and the Doppler signal shows good blood flow. And the image B here is the transverse section, and A is the longitudinal section. So on B, you can see the blood flow, completely filling up the lumen. Whereas if you look at image C, you can see that there is a hypoechoic layer just here, if you can see my cursor, and that is consistent with vessel wall edema, and you have that in inflammation. So this blood vessel here suggests giant cell arteritis. It's inflamed. It's a thick inflamed wall full of edema. And the transverse image, you can see that hypoechoic again layer around, and it's what we call the halo sign, and this is what we look for in giant cell arteritis. So if a patient has an ultrasound scan and the appearance is like image C and D, we'd be fairly confident that this patient has giant cell arteritis. And if they have a biopsy, which is the gold standard to clarify the diagnosis, on the left here you have a nice healthy temporal artery. The wall is nice and thin, and you've got the lumen, which is patent, allowing good blood flow. And on the right here you've got thickened intima due to proliferation of inflammatory cells, and then you've got giant cells here on these arrows pointing to giant cells, and here there's one as well. And you can see how thick that blood vessel wall is and how small the lumen is. So you can appreciate that if a temporal artery has this appearance, then the pulsation is going to be reduced. It will be very hard to feel the pulse, and the pulse might even be absent. And if it happens in the large vessels like the femoral arteries, then that's when the patient develops symptoms of claudication. So in terms of management, if you see a patient with suspected GCA, in A&E or in a GP setting or on the wards, then please feel free to call the rheumatology registrar or the consultant on call via switchboard, and we can discuss. If the history is very suggestive of GCA and we have raised inflammatory markers, we would advise to start prednisolone straight away and arrange to see them in rheumatology within a few days for a review. So in uncomplicated GCA, and by uncomplicated I mean no visual symptoms and no jaw claudication, so no ischemic symptoms, you would prescribe 40 milligrams of prednisolone daily. But in cases of complicated GCA involving visual loss, you would need to ask the patient to go as a matter of urgency to the eye infirmary to get their eyes checked. And if there is any ischemic changes at the back of the eye, the ophthalmologist would recommend starting IV methylprednisolone at the dose of 500 milligrams to 1 gram over 3 days, and then we can take over from them for the ongoing management of steroid. So in established visual loss, we can't really do anything for that eye, unfortunately, and starting steroid would not bring the vision back. But what steroid will do is to protect the contralateral eye. So you would need to give 60 milligrams to protect, the other eye. And traditionally, we've been using aspirin as well in patients with GCA to help with the circulation of blood. But the latest guidelines now do not recommend aspirin anymore, although some consultants are still using it in our department. So in terms of prescribing steroid, it's a treatment that needs a lot of counseling before we start it. So we should advise patients not to stop steroids abruptly. So if they are running out of tablets, they may need to make sure to get a further prescription from their GP. If they have been on steroid for more than 2 months, then the dose need to be increased if they become acutely unwell to avoid an Addisonian crisis. And we need to warn them regarding the risk of raised blood sugar, especially in diabetics, and they would need to monitor their BMs more frequently. And we need to counsel them regarding side effects of steroids. So do you know any side effects of steroids? Or?
Yes. So weight gain, osteoporosis, cushingoid features. What else?
Yeah, so that's good going. So there's things like skin thinning, bruising, insomnia, risk of infection due to immunosuppression, and I think...
Well, I have to say psychosis because I know geriatrician as well.
Psychosis, yes, psychosis. Avascular necrosis of the long bones, osteoporosis, glaucoma, cataracts, diabetes, and in time of COVID pandemic, I think the infection risk of steroid should not be underestimated. So we don't want to start people on steroid unless they absolutely need it. And it's really important to get the diagnosis right. And especially, as people with GCA tend to be older patients, so they would be in the at-risk population of COVID-19. So you need to be quite fairly certain before starting people on steroids. And then if you are starting the steroids, so think about side effects like stomach ulcers, heartburn. So we always prescribe it with a proton pump inhibitor, and also think about burn protection, so whether they need Adcal D3 and alendronic acid. And then give them a clear plan regarding weaning it. So we do have a steroid booklet where you can write down the dates, about the steroid doses, how long you want them to keep going with the 40 and then reduce down. So it's important to write it down for the patient so they don't get confused about it. And in rheumatology department, we do have information booklets about giant cell arteritis and prednisolone. So we give out the information booklets as well. And don't forget to counsel them regarding the risk of blindness. So although if treatment is started, this risk is small, but it's still there. So they need to know to attend the eye infirmary if they develop any symptoms in their eye, in which case they would require IV methylprednisolone. So usually the tapering regimen we use is 40 to 60 milligrams of prednisolone until the symptoms have resolved and the inflammatory markers start to normalize. And that usually takes about 3 to 4 weeks. And then we would have a slower tapering of the steroid, as you can see on the slide here. And it can take up to a year or 14 months for the patient to come off steroid completely if they have not had any relapses. But you can imagine if there's been several relapses, then that will be longer. So we tend to follow them up in clinic for a few years, so they can have a chest x-ray every 2 years to monitor for aortic aneurysm, and they may have relapses even when the inflammatory markers are normal. If the headache return, they should be treated with the previous higher dose of steroids, and usually on a third relapse, or if we can't bring the steroid down further beyond a dose, then we would introduce a steroid-sparing agent like methotrexate or tocilizumab, which is a monoclonal antibody IL-6.
Do these patients often come off the steroids completely?
Yes, so we have seen them, some people are fine coming off the steroid, but I think if that happens, then we can discharge them from rheumatology, and then GP can re-refer if they have any recurrence.
That's one of the things we see a lot, especially with polypharmacy, that these patients, especially with not necessarily GCA, but maybe the PMR patients end up on steroids for
a long time,
and that becomes very difficult to talk to patients about.
So I think in PMR it's more likely for them to require a maintenance dose of prednisolone, about 5 milligrams in the long term. But for GCA, I think most of them should be able to come off. And that's the end of the presentation. Thank you for listening.
Thank you very much. I was going to ask one question. I guess this is, again, related to the PMR kind of thing, but this is, I guess, the issue with ESR. And one thing we know that is in older patients, ESR can be even, I mean, I think it's normally around 10 is normally the upper limit kind of thing allowed. But in older people, it seems to be that you're allowed a higher ESR.
Yeah, so for male patient, usually it's the age divided by 2.
Right.
And for female patients, it's age plus 10 divided by 2.
Right, okay, fair enough, okay.
Yeah.
So like if you had, say, an 80-year-old patient who was male, we'd
So
allow
then
40.
40, yeah.
Fine, okay.
Yeah.
That's really useful because actually we see a lot of patients refer to us with raised ESRs. Is this PMR? And they may come to yourselves, they may come to us.
Yes, yeah.
You know, because a lot of elderly patients have generally aches and pains or headaches.
Yeah.
And that's a really useful calculation.
Yeah, so I think,
Yeah, no, that's really useful. Grand. I think this is one of the things I find with GCAs. It's one of those great mimics. Like the headaches, cluster headaches, good example. But also people often think about other types of headaches, like the big ones, the thunderclap ones. But also this is more
migraine.
anterior and migraine.
Yes, migraine. Yeah.
But also the other thing I've seen similar to that people get is vascular events. So thromboembolic, because obviously the narrowing of the blood vessel can often look like a vascular event, a thromboembolic event as well, and I think that's very interesting where this comes into.
Yeah.
I saw some interesting cases I might talk to you afterwards.
Oh, right, okay, but don't forget to check the inflammatory markers, because in the vascular event you wouldn't really, unless there's concurrent infection or something else going on.
And especially with these ones as well, you get more broad vascular events, so therefore it becomes law of averages means unless you've got like a cardiac embolus, you're not going to get multiple sites.
Exactly.
Which therefore makes me think
it's to do with the vasculitis. Yeah.
No, that's very interesting. Thank you very much.
You're welcome.